Assalamu alaikum, good morning, good afternoon, and good evening, wherever you are. So we welcome you to our public health webinar. I'm Muhammad Abid, a professor in the Institute of Public Health, College of Medicine and Health Sciences, UAE University in LA. This webinar is part of our global campaign, This is Public Health. We're also very proud to be affiliated with ASPEC, which is the Association of Schools of Public Health in European region. We are organizing these webinars monthly with the aim of bringing interesting speakers in order to highlight different important public health issues. Our webinars are accredited by the UAE University as one CME. So in today's webinar, you will be able to ask questions and you can do so by clicking the Q&A option in the middle of your screen. You can submit your questions during presentation, and we will try to cover your questions in the end. At the end of the webinar, we will share a link in the chat for the evaluation of the webinar, and you need to fill in the evaluation link to obtain your certificate. I think that's very important. This webinar is recorded, and the recording will be uploaded to our YouTube channel, Institute of Public Health, CMS, where you can find recordings of our previous webinars as well, posted by the Institute of Public Health. Right, so we all know that our health has many determinants, like individual factors, physical factors, socio-economic factors. And COVID-19 pandemic has highlighted the importance of social and environmental factors, resulting in the discrepancies in mortality, morbidity, and healthcare access among different groups in our communities. So today's presentation title is Introduction to the Social Determinants. And our speaker today is Dr. Lorraine, and we are very honored that she accepted our invitation. She is an associate professor in the epidemiology at the Hopkins School of Public Health. As a social epidemiologist, her work focuses on privilege and health, including social and economic determinants of disparities, especially in cancer and HIV. She has led several studies as a principal investigator of NIH and Center of AIDS research grants. She holds a doctorate from the Harvard School of Public Health, and she's also a Fulbright Program awardee for Venezuela. So now I will request Dr. Dean to take the virtual floor for her talk. Thank you very much, Dr. Dean.
Thank you so much for having me, and good evening, everyone. I'm going to start to share my slides with you. All right. So thanks again for having me. Today, I'm going to be talking with you, giving you an introductory lesson on social determinants of health. And I do this from my perspective as a social epidemiologist. I am in an epidemiology department at Hopkins, where I'm an associate professor. And we're going to talk a little bit about what that means and how my work as a social epidemiologist is different a bit from clinical epidemiology, and how that can influence our understanding of various types of risk factors for health and disease. So today, what I hope that you walk away with is that understanding what makes social epi different from clinical epi, understanding how do social factors contribute to health, what are some of the ways, and what sort of methodological approaches can we use that we use kind of distinctly as social epidemiologists to understand how social factors are linked to health. We're going to talk about a little bit at the end. I think what's really important is that you will not walk away from this lecture being a social epidemiologist. No more than one lecture on cardiology makes you a heart specialist. This is really intended to get your feet wet in understanding what particularly social epi does and the types of ways that we make unique contributions to science. So before we go into social epi, let's start with what is epi. Epidemiology is defined as the study of how disease distributions are distributed in populations and the various factors that influence or determine that distribution. So it's this idea that diseases, illness, and health are not really randomly distributed in populations, but instead that there are certain characteristics that make some people more or less likely to get disease or stay healthy. That could be genetic factors, environmental, behavioral, or social factors. And when we talk about the birth of epidemiology, we talk about this person named Jon Snow. So for those of you who watch Game of Thrones, it's not that Jon Snow, it's this Jon Snow, who was a father's son and a physician who treated cholera during the 1800s in London during the cholera pandemic. So at the time, people believed that disease, and particularly cholera, was due to something called miasma, or bad air or pollution. But that's not what Jon Snow eventually found out. And if you trace any intro epi course, you'll probably hear about this story. And I actually visited here this past year. I was in London this past year and visited this pump. But the idea was that Snow and others had believed that the root cause of the problem was actually in the tainted water supply, not the air, not the pollution, not the miasma. And he used a map to explore his findings and essentially plotted out each of the water pumps and plotted out some of the cases of cholera that were happening around that area. As the story goes, he goes and breaks off the water pump and the cholera rates drop. And what that really showed is that place matters. And place matters because of who and what you're exposed to, both socially and physically. Now, around the time of Jon Snow's observations, other people had been writing about things about how overcrowding, how damp and filthy living conditions contributed to lower life expectancy. So there was this growing recognition that people were realizing that these social factors affected health. And I think it's really important to think about what Jon Snow's contribution was, because much in the same way that Jon Snow's idea was to reframe the cause of the cholera epidemic, the goal of a social epidemiologist is to reframe the cause of disease and health as social factors. And that's what we often try to do and try to help people understand. Now, I'd also say that even though Jon Snow is heralded as the father of modern epidemiology, a colleague and I wrote a paper arguing that there's someone who should be recognized as the founding father of social epidemiology. And we thought that accolade should go to someone named Dr. W.E.B. Du Bois. W.E.B. Du Bois was alive also in the 1800s to the mid 1900s, so a little bit after Jon Snow, not quite a contemporary, but a little bit after Jon Snow. He was in the United States and he was a sociologist, and he was actually the first Black American to earn a doctorate. And what W.E.B. Du Bois did was he looked at the relationship between the social environment in Philadelphia and the mortality of Black people living in Philadelphia at the same time. And he used a number of different types of data he used a number of different types of data, including visualizations, he used qualitative interviewing, he used survey data to think about what were the causes of disease, particularly for Black Americans in Philadelphia. And in our paper, we contrasted that with what Jon Snow did, that they essentially did very, very similar things. Yet, even though Jon Snow is heralded as the father of modern epidemiology, W.E.B. Du Bois doesn't really ever get recognized as the father of social epidemiology, as we believe he is. So I encourage you to read this paper and hear more about W.E.B. Du Bois's contributions so that we can elevate this person's science. But it also reminds me of that when we fail to think about the various heroes that we have and the various people that have contributed to this, what are the types of things that we might have missed? And what are the things that we have been missing about what patterns health and disease if we would have recognized W.E.B. Du Bois' contributions earlier? So what else was going on at the time? There were also other people particularly in medicine, that were thinking more about social factors as contributors to health and disease. So one such person is Rudolf Virchow, who was a German physician. He did anthropology, pathology, historian, had a lot of training and had very strong views on the need to combine things like physiology, microscopy, and experimentation to prove scientific and medical hypotheses. Now, it's important to think about the context of the time and what people at this time might have been seeing in front of them. So all of this happened, and the work of Rudolf Virchow happened around the time of right after the Industrial Revolution. So that was a time when new manufacturing was booming, and it was really impossible to ignore the extent to which things like the factory system and the impoverished workers working at the factory system, and how that came together to create poverty and disease and even workplace risk. What Rudolf Virchow's work found is that there was a strong association between poverty and indicators of ill health. And that really started placing a greater emphasis on social factors as drivers of health and disease. They also found other things that were attributed to poor housing, sanitation, and work conditions. And Virchow really added looking at the political and economic conditions and asserted that poverty creates disease and that reform or revolution would be needed. And that, in a sense, medicine and the steps taken to promote health and combat disease had to be social as well as medical. This was really revolutionary for the time. Also around that time was the work of Émile Durkheim, who was a French sociologist who studied suicide. And now, while suicide seems to be an individual act, its etiology really lies in the social structure and the impacts it might have on behavior. And Émile Durkheim brought together geographic, demographic, psychiatric, and social research methods, brought data with a strong theoretical framework to understand what people originally thought of as only an individual behavior, and understand the context around that behavior. And what Émile Durkheim did was look at suicide rates in French and German cantons. A canton is a geographical subdivision, so it just represents a particular area of town, and looked at differences in suicide rates by people's religion, and was really thinking about how people live, where people lived, and the religion of the people who lived there might actually contribute to suicide rates. So in Durkheim's study, he decided to compare cantons that were majority Catholic religion and compared to those that were mostly Protestant, and as well as those that were relatively mixed, and then looked at the suicide rates in that areas. And that's what you see pictured on the chart here. What he believed is that Catholicism and Protestantism's doctrines gave people a different set of beliefs about how to interact with the world that would then somehow map onto changes in suicide rates. And what he found was that when he compared those cantons in France and Germany based on the religion of the people in that area, he found that the areas with large proportions of Catholic populations had lower suicide rates than areas with those with higher Protestant populations. And here you can even see that there's a bit of a, I would say, dose response, or a bit of a gradation, where you see that the mixed areas were right in the middle between the two. So part of the reason that he believed this is because of the fundamental doctrines in each of these religions. That Protestants, he believed, gave freedom to the individual, while Catholicism talked about social integration, and essentially believed that what was happening is that under Protestantism, that people were too individually focused and isolated and weren't reliant on on their social networks as much. And because they were less socially integrated, led to greater isolation and higher rates of suicide. Other people who were doing work a little bit later was, for example, people like Saxon Graham. Well, I should say, actually, Saxon Graham was actually earlier, but Saxon Graham, the reporting of Saxon Graham came out much later after Saxon Graham was alive. So Saxon Graham was an epidemiologist who spent a lot of time studying cancer. And part of the reason, in the state of that time, was there was a decrease in infectious diseases due to vaccines. So that allowed longer life expectancy. And so now we see the rise of chronic diseases like cardiovascular diseases and cancer, which we knew had multifactorial causes. That really distinguished infectious diseases, which people could trace oftentimes specifically to some particular virus. But now that we think about these diseases that are chronic diseases, we need to think about a wider ranges of causes and the various combinations of those risk factors that might be patterning who gets those diseases. What that gave rise to is something that we call risk factor epidemiology. But basically, Saxon Graham really helped develop our multi-level thinking, even decades ahead of the field of thinking about risk factor epi. So right around this time, people had started thinking about the need to integrate sociology and medical science in order to do good, successful epidemiology work, and recognizing that it would take both social and biological data to understand why people were getting certain diseases. They also wanted to understand, for example, how social group membership and behaviors that happen and are reflected in groups, how those might influence things like tissue changes or disease. And then also thinking about the find which social circumstances could lead to specific behaviors, and then how those specific behaviors would lead to specific diseases. And Percival Pott is an example that Saxon Graham helped bring out. So Percival Pott was an English surgeon who did some work in the 1700s on scrotal cancer in chimney sweep. And he talked about something that he called the chimney sweep's carcinoma. And he said, it's a disease which always makes its first attack on the inferior part of the scrotum, where it produces a superficial, painful, ragged, ill-looking sore with hard rising edges. So essentially, what he was observing is that there was scrotal cancer happening in young boys who were chimney sweeps. And he commented on the life of the boys and said, the fate of these people seems peculiarly hard. They're treated with great brutality. They are thrust up narrow and sometimes hot chimneys where they're bruised, burned, and almost suffocated. And when they get to puberty, they become liable to a most noisome, painful, and fatal disease. And if you think about scrotal cancer, that's not something that you would expect to see among young boys. This is, again, a chronic disease that you would expect to see among potentially older populations, but started to see it among these young boys and decided to think about what are the factors that might contribute to now young people having a disease that they really shouldn't have. So in taking, you can see some pictures here, and I want you to just to take a moment to reflect on what you see in these photos. These are photos that represent the association between the type of exposures that these young boys were having and the reasons that they were having a higher incidence of scrotal cancer. So I'll just pause for a second and let you take a moment to look at these and what you see in these chimney sweeps on these photos. So a couple of things that you might notice is that the chimney sweeps, which you see pictured here and here, and here even in this cartoon, they're usually young boys, and they had to do a very dangerous job of climbing through hot flues, which exposed them to soot, or hot chimneys, which exposed them to soot. And in fact, if you can see in this picture right here, the child's face and arms and extremities are completely covered in soot. They had to climb through these chimneys where they just got soot covered. And they often were never washed, and were often street boys who were living in poverty, who in some cases were abducted from their families or taken from their families to pay a debt or something like that, and then subjected to these jobs. You can also see here in this picture an adult scolding the young boy. You could see some of the harsh treatment that they might be facing, as well as potentially being forced to do some of these jobs that would then expose them to, it'd be an occupational exposure to a chronic disease. So there are a couple of things that were happening at the time to understand this. One, there was an environmental need for heated dwellings. There was a preferred fuel produced, much smoke and soot. There were exhaust passages that required frequent cleaning in order to keep these houses heated and to manage that sort of fuel that was being burned off. And this was an occupation which put the worker in close and frequent contact with the soot that eventually would cause the scrotal cancer. So on one hand, the immediate exposure that these chimney sweeps faced was this carcinogenic soot. However, what was the underlying root cause of why these boys were getting scrotal cancer at such a young age? That root cause, we would argue, is poverty. That was really underlying the reason why all of these boys were getting these diseases. So we needed to understand both the social environment, again, as well as to understand why certain populations, and in this case, young boys, were getting specific diseases. And you'll hear about that as a common theme throughout social epi and social epi work. So as we move forward in history, there's the emergence of things like social medicine in the UK in the 1940s with the promise of the national health system. And the word itself, social epi, wasn't actually used until 1950. The first time it was used was in a paper by Alfred Yankauer on the relationship of fetal and infant mortality to residential segregation. That was the first time the words social epi were actually used. And I want to make it a point that this was 1950. This is not that long ago. 1950 is relatively recent if you think about, for example, the history of medicine, which we think about for hundreds and potentially even thousands of years. When it comes to social epi, we are a very, very new field. I mean, at this point, in maybe 70 years old, even though the roots of our work, at least in a named way, but the roots of our work actually span back into the 17s and 1800s and possibly before that, because I do believe that many of the histories around this work, we probably even haven't uncovered or fully explored the contributions that many scientists have made over the course of history. But in terms of actually being able to call ourselves a field, that's really happened since the 1950s. We're relatively new. And since then, there's been a growing interest in this area. In the 1960s, people started thinking about applying social epi in other words. So Jaco's paper on social epidemiology of mental disorders. And then in 1969, Leo Reeder at the American Sociology Association really fully recognized social epi as the study of social factors in the etiology of disease, and really started putting social epi, so to speak, on the map in the 1970s. Soon after that, John Castle produced the Wade Hampton Frost lecture, where John Castle further decided to elevate the social epi perspective. So John Castle was a faculty member in the department at University of North Carolina in the Department of Epidemiology, and did major focus, and actually was on faculty and chaired the Department of Epidemiology at Hopkins at some point. But John Castle's major focus was on the social environment as a determinant of health in populations, and used the area of Evans County as a lab, this Evans County in North Carolina as a lab, where he shifted from thinking about rural to urban residential living and thinking about stress factors. So in order to make his observations, John Castle used Evans County, Georgia as a lab. And that was a place that was shifting from rural living to urban industrial living, and as a way to assess what sort of stress factors might change as someone shifts from living in a more rural environment to a more urban environment. So this type of work laid the foundation for the types of things that we look at today in terms of social epi. And what Castle talked about, what Castle really elevated, was that whether individuals developed one disease or another depended on their behavioral or environmental exposures, as well as their biological or genetic makeup. But whether or not they became ill or died at earlier ages, or whether specific socially defined groups had greater rates of disease, depended on socially stressful conditions. And that's actually a quote from chapter 1 of our social epidemiology book that was written by Kawachi and Berkman. So essentially, the idea behind Castle's work was thinking about epidemiologic inquiry and the ways in which subsets of people would become more or less susceptible to different agents that were in the environment. And I think that's important to recognize, that not simply because people live in the same environment doesn't necessarily mean they still have the same susceptibility to a disease. Instead, there's a cross-section of someone's individual risk and their social environment that leads to their personal disease susceptibility. However, environmental conditions could produce profound effects on people's susceptibility. And Castle talked about some work that he did with Mervyn, which focused on things like nutritional status, fatigue, work conditions, psychosocial stress, and social supports. So when we think about social epi, we call it the branch of epi that studies the social distribution and social determinants of health. And that is what we would say both the specific features of and the pathways by which societal conditions affect health. And we don't just think about this as the individual level. In fact, it implicates looking at across levels. For example, using things like multi-level modeling or other things to fully incorporate and to distinguish the contributions of things that happen at levels outside of the individual. So social epidemiology is really distinguished by its insistence on explicitly investigating social determinants of population distributions of health, and instead of treating those things as background to biomedical phenomena. And that's really important, that we don't want to treat the social factors as background, but as social epi people, we treat these as thinking about these as the driving forces. And that can include all types of things. It can include a society's past and present economic, political, and legal systems. It can include their material and technological resources, Or it could be things like social norms and practices that are consistent with what we consider as our human rights norms and standards. It can also introduce or think about external political and economic relationships with other countries. So that is to say that sometimes these exposures are within our own societies, but many times what's even within our societies is patterned by external forces outside of our societies and what we are exposed to within our societies and what we can be exposed to. So to give you some thoughts about what we mean, kind of taking this from the abstract to something more concrete. When we talk about the social determinants of health, we're talking about a couple of things. A lot of times we're thinking about things like economic factors, like socioeconomic position. And that can include people's employment, income, debt, medical bills, support, and other things that they need. Or we could be thinking about the neighborhood environment, things again outside of the individual, housing, transportation, safety, parks, play spaces, how walkable an area where you live is, or play or work. We also think about education, what type of quality of education, the type of education, and how much education is available. It might be thinking about, if we think about something like food, we might be thinking about hunger. We might be thinking about whether or not someone has access to healthy options or potentially lives in a food desert. We might also think about the community context. How integrated are communities? What sort of community engagement is there? Is discrimination happening in those communities? And in the work that I've done, that I did as a doctoral student under Ichiro Kawachi, I looked at things like social capital and how someone's social capital could help frame people's health behaviors. And then there's the other things like the healthcare system. And that could be thinking about whether or not someone's have access to healthcare, what sort of providers are available, whether or not there's bias in that relationship with the provider, and what sort of quality of care that they're getting in terms of are their needs being met, and are those needs being culturally consistent with what they believe culturally, and what sort of linguistic accommodations they might need. And then we look at health outcomes all across the spectrum. Some of them are as extreme as mortality and morbidity and life expectancy, but then there are other things, just healthcare expenditures, health status, and other functional limitations that someone might have. But I'd also say that a lot of social epi really thinks about prevention and thinking about how do we intervene on risk factors, or how do we think about risk factors and their role in preventing people from getting future diseases that they could potentially otherwise avoid. So we think back to the Percival Pot example or the chimney sweeps example, we might think about what would happen if those boys had not been in poverty, right? Those are diseases and those are cases of scrotal cancer that we would have prevented. We would have saved some additional lives. When we think about preventive medicine, we think about it from the Jeffrey Rose strategy. And Jeffrey Rose's strategy of preventive medicine is predicated on a couple of things. One is that individuals are embedded in populations, and that if we believe that the individual risk of illness has to be considered in the context of the population, of the risk of the population that person came from. And that risks are not just separate and distinct, that they're distributed across a continuum. So some people in that population will have more risk and some will have less. But that if we make small shifts in that distribution of risk, we can make large differences in the health of a population. And inherent in Jeffrey Rose's approach was that social conditions are part of the social determinants of health. And that is the belief that these risk factors could predict disease, but they don't necessarily cause the disease or predict benefit from an intervention. And that's really an important distinction. Yes, we talk about, for example, going back to the chimney sweeps, poverty is a potential root cause of the chimney sweeps, but we know that the most immediate and proximate cause was the carcinogenic soot. So in this case, the risk factor itself could tell us, potentially looking at poverty alone could probably tell us who was likely to get the disease. But biologically, it wasn't causing the disease. And it wasn't necessarily telling us how much reduction that we would get if we could eliminate poverty for those boys altogether. So it doesn't necessarily predict the benefit from a particular intervention. And this was really pronounced for us for people in the United States when we had a hurricane in 1995. It was Hurricane Katrina. People say it was the single most catastrophic natural disaster in the U.S. history. And according to our emergency medical estimates, The total estimated damage was $108 billion, which also made it the costliest hurricane in the US history. And there were really damage and health effects that disproportionately influenced, again, particularly those who were in poverty. So as you can see here, you can see the total population, you can see who's in poverty, but you can also see, and this is the estimated number of people who were flooded or in storm damaged areas, that we see some differentials both by the race of the person as well as by the poverty level of the person. And what we found was that even though poverty was a risk factor, but poverty didn't necessarily cause deaths due to Katrina. Those were due to the flooding, right? Poverty wouldn't cause them. And that taking people out of poverty might not have necessarily reduced the health effects, but it could at least tell us who might be most likely to be influenced, and that we should then be focusing on assessing what is the reversible risk. So in addition to being able to name what those risk factors are, we also should think potentially separately about what we can do in terms of reversing that risk, which again may or may not be actually addressing that specific risk factor. And I get this question a lot when I talk with medical audiences. People say, well, aren't risk factors mostly biological? Well, we actually find that that's not true in the empirical studies that we've done. So we found a couple of things. One, when we look at twin studies, for example, only about 20 to 30% of the variation that we see, for example, in survival to 85 years is determined by genetics. And these are just some pictures of famous twins that you might have seen. The Olsen twins, Rami Malek and his twin, and the Tia and Tamara Mowry twins. So our twin studies suggest that only about 20 to 30% of the variation that it sees in one of our most extreme examples, which is time to survival, is determined by genetics. But if we look at other things, if we look at, for example, medical care is really responsible for about 10 to 15% of preventable mortality. And then other people would talk about things like health behaviors, that major health behaviors count for about 20%. So all that to say, and especially in the case of health behaviors, as well as things like medical care, both of these are social factors. There's also much room for growth in appreciating the contribution of social factors outside of things like genetic factors. And arguably, if only 30% is due to genetic factors and the rest is due to things that are socially patterned, it really shows us where we should be putting our emphasis and our thinking, and if we want to further prevent disease. So where do we actually really think about, where do we actually look for these causes of disease now? If it's not social, what has it been? Well, we talked a little bit about Virchow and some of the other people, that for a long time, people thought about this as the social environment, its etiology. And at the time, people mostly thought about sanitation. People thought about cleanliness. But now we've arrived at a point where we're thinking more about these social causes of disease in a population perspective. But largely, we still suffer from a challenge that we call being prisoners of the proximate. That when we want to think about risk factors, we often think about these proximate risk factors, things that we can control at the individual level, and that often we say reflect Western values and beliefs of that inability, that the ability of individuals to control our own fate and the importance of doing so. But we know that that's just not true. We know that we can only really do so much individually to impact our health if we're not put in a context that can actually help us be healthy or avoid disease. So we talk about being prisoners of the proximate, that we often want to focus here on the individual level risk factors that we see are mostly related to what we believe causes the disease. And why is that? I mean, in some sense, right, it's difficult to see what these distal factors might be, what these social factors might be, even though we do have evidence of that, but also because it's often hard to change societies. And when we consider proximate causes, it causes us to think that disease is represented among individuals. But when we consider distal causes, it causes us to what we say look upstream. That is, consider that there's this manifestation of disease that could look very different at the population level and is more than the sum of the individual risks that we see. When we talk about upstream and downstream determinants of health, Paula Braveman refers to upstream and downstream, talks about things like economic and social opportunities and resources as being the framing for what leads to our downstream health outcomes. But those are also, living and working conditions are also embedded in these larger society, as well as medical care and personal behavior. And I think another way to think about this, and maybe a simpler approach, is to think about how the various levels at which things influence our disease outcomes. So if we go from the upstream, we might say these social and structural conditions that 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 condition the extent, shape, and nature of our health and disease outcomes. Our social networks, which provide opportunities for people to be healthy or less healthy, and our psychosocial mechanisms that impact health through a number of pathways, which then lead to our downstream factors. So the idea is that our bodies biologically express the social conditions they experience. And this happens over the course of life and across various social gradients based on people's groupings in society. And what it points to is that there might be biochemical processes, there might be pathways and candidate systems that may be affected, but they might be affected at different times of life. So for example, when are social factors important in terms of how they influence people over their life course? Well, we have something that we call life course epi. And again, this is an intro lecture, so I'm just giving the highlights of what life course epi looks like. But essentially, we talk about there being latent effects, critical periods, and sensitive periods. So latent effects is the example that an early life environment affects later health outcomes. A critical period would be a window in which, when you're exposed to something, adverse or protective, that could affect development and disease outcome later. But if you do something outside of that window, there's no excess disease risk associated with exposure. Or there's also something that we call a sensitive period. That's a period when an exposure has a stronger effect on development and subsequent disease risk than it would at other times. So for example, a sensitive period example might be lead exposure. If you have lead exposure when you're very young, it has very negative effects on cognition throughout childhood and adulthood. But it's particularly detrimental when you have lead exposure when you're ages 1 through 3. So I have an example, and I'd like you to just think about what you think, what type of latent effect this might be. So this is a picture of my 2 cats who are somewhere in this room with me in my home office. But something happens if you cover the eye of a cat when they are a kitten, the visual cortex doesn't develop, and the kitten is always blind in that eye forever. But if you cover the eye of the kitten at a later time, nothing happens, right? If I cover the eye of my adult cats now, they would just not be able to see for a little bit. That's an example of a critical period because it's something that is critical, that is an exposure that has to happen critically at a particular time in order to have a particular set of effects. So how do these social factors get under our skin? Bodies biologically express the social conditions they experience. It happens over the life course and it can be influenced at different times. And again, points to these biochemical processes. And again, these things are happening at different levels. So there might be these upstream factors that influence our health behaviors. So that means that these upstream factors could cause a stress response for which behaviors are a coping strategy. So for example, if you think about some of the, let's see, for example, if you're in a largely stressful environment, that might lead you to rely on certain substances, which because of the stress in your environment, and you might be doing that as a coping strategy. It could also, for example, help shape norms through people and environmental cues. For example, mutual trust is linked to lower homicide rates, and social acceptability of things like gun violence increases the likelihood of gun violence. Or it might be something like enforcing patterns of social control. That is control and social support. So let's say maybe it's okay to take a break during lunch, or maybe at your workplace, it's okay to leave early. That is a pattern of social control. It's not an actual rule, but it's a pattern of social control that might influence your health. And then there are other things. There are environmental opportunities to engage in a behavior. So for example, there might be physical conditions in a workplace that lead to poor ventilation, or if there's a lot of noise, or going back to our chimney example, right? Having physical and hazardous chemical exposure, those sorts of things, those might also influence health. And it's important to recognize that these factors might be health promoting or health damaging. It can go in either direction. And this doesn't just happen at the individual level, but we also think about how this might influence the health of a population. So we know, for example, at least at the individual level, this biological embedding can occur when a couple of conditions are met. Again, this is what we in social epi call as how social factors, quote, get under the skin, and ways in which it alters human and biology and development. So what we know is that there are systematic differences in experiences in different social environments in society. And we know that especially happens early in life. And that pushes people into different biodevelopmental states. These differences tend to be stable and long term. So again, these influences that happen at certain periods of time affect you over your lifetime, usually not just at one point in time. And those differences have the capacity to influence all types of outcomes, which could be health, well-being, learning, or behavior over the life course. And oftentimes this is linked as a process that happens to individuals. But individuals, as we said from Jeffrey Rose, are embedded in populations. And even individual risk can contribute to population risk. We usually think about that in terms of infectious disease, right? We all seen this with the COVID-19 pandemic, where someone's individual risk was affecting, individual susceptibility was affecting everyone else's risk and susceptibility. But I'd also argue that we can see this in other things, maybe non-communicable diseases, because even in this embeddedness, even when this embeddedness happens, that can have implications on, for example, healthcare systems and other things that actually influences other people's ability to stay healthy. So it's a complex interplay of various systems. So again, to move into the closing, why do we care about social factors, especially even when we think about not just individual level health outcomes, but population level health outcomes? Well, at the individual level, we know that they influence things like the length of life and quality of life. At least health outcomes are about length of life and quality of life. But we also know that health behaviors, which are patterned by things like our policies and programs, health behaviors are drivers of population level health. We also know that clinical care, like access to medicine, is a driver of population health. We know that our physical environment is also a driver of population health. So those are things like air quality and whether or not we have adequate transportation and housing. And importantly, social and economic factors that we talked about before, things like education, employment, income, family and social support, and community safety. So that is overwhelmingly contributing to our population health. And these also might be points when we can think about both risk and risk prediction, as well as thinking about where and when do we intervene, which may or may not be on these factors. It may actually be on some of these other factors, but we have to understand that they happened in the context of these factors. And in order to do that, in order to think about looking upstream, we need to think about a couple of methods. And these are methods that we tend to use in social epi. One is what we call contextual multi-level analysis. So it's this acceptance that many behaviors are conditioned by society, and that requires us to be able to account for both what's happening at those higher levels as well as what's happening at the individual level. And in fact, the neat thing about multi-level analyses is that they enable us to parse apart how much of an outcome is due to something, for example, that's happening at your neighborhood compared to what your individual level risk or contribution might be. We also use things like ecological study designs. So epidemiology and sociology since the 1930s has focused on what we call ecological analysis. It's a way to study environments. And the idea with ecological analysis is that it's something that we would not attribute to individual level factors. It's something that we would think about in terms of what is something that we can look at across a population, but doesn't necessarily have an individual level analog. So I'll give an example. It might be the density of grocery stores or the density of parks or whether or not there are boarded up homes in your area or something like voter turnout. So things that aren't necessarily individual level factors, but things that are happening in the environment. Some of the challenges, though, is that we have to be able to it's hard sometimes to disentangle between what is the components of the ecological outcome that we're looking at versus how the ecological outcome itself is contributing. It can be difficult to understand the pathways to link these exposures to individual health outcomes. And then also, so much of our thinking, again, is on the proximate, that when we theorize is about cause at the individual levels, but then we're estimating effects at the population level. And that creates a disconnect because, as I said before, what's happening at the individual level might not exactly map onto what's happening at the population level. So where are we? Today I've given you just a really fly-by-night overview of what the many types of things that social epi does, the types of social factors that we consider. But it's also, as I mentioned before, a fairly new field. So where do we go next? Some of the things that Sandro Galea has proposed and things that we need to be able to do in social epi are greater understanding of the mechanisms of how these social factors are embedded into individuals and then how that influences population health. We need a better understanding of intergroup differences and inequality and how those play out. We need to do some methodological innovations. There's a lot of methods that we use in clinical epi that aren't exactly translatable to social epi because we don't think about risk factors as discrete or risk factors as isolated. We think about risk factors as being a context. We also need to think more about social interventions. So much of social epi work is focused on identifying the risk factors, but we haven't necessarily got to the point where we're thinking about, well, now that we know who's at risk for a particular disease because of this social factor, what do we need to do to intervene? And then we need more on theory. We didn't talk a lot about theory today. There are a couple of theories that exist in social epi, but for the most part, we didn't get to talk about those. But we do need actually more theory development, especially as we think about not just individual impacts on health, but individuals on population health. And then as well as making sure people are trained in understanding the various levels of influence, working across different types of fields. And again, as I mentioned, theory development. All right, so just to recap, a couple of things I want to make sure that you take away from today is that social epi is a relatively new field, though it has old roots, and that uses epidemiologic methods to investigate the social determinants of health. If anything, I want you to think through the ways in which the social roots of disease are upstream factors that occur over the life course and that are embedded biologically. And I want to challenge you as you go throughout your day, think about the things that you do and think about how the things that you do are related to how you grew up and where you are now, and what some of those factors that might be that lead you to do what you do that might be healthy or not healthy. And then also think about how those factors directly and indirectly influence health through framing your behaviors or potentially psychological and physiologic responses to the world. I'd also say if you're interested in more, and this is actually an advertisement from a little while ago, but I do also teach a full course on the foundations of social epi at Hopkins over the summer. These are not the dates. I'm not sure what the 2023 summer dates are, but I do have an entire course. It's about 3 weeks long where we go more in depth into these topics. And I'd love to have you join the class and learn more from you about the ways in which you see social factors influencing your life. All right. That's all I have for you today. Thanks so much for listening. Thanks so much for joining this evening. And feel free to follow me on Twitter if you're interested in more of the work that I'm doing. And I'll take time for questions. Thanks so much.
Thank you very much, Dr. Dean. It's very interesting and thought-provoking talk. And you have taken us through a journey, which I guess, in more recent times, it started maybe 200 years ago, especially the way that things were happening in the 17th and the 18th century. And then with the Industrial Revolution. So I think, thank you for taking us through that journey. And over the time, how we have a better understanding, because humans are the social animals. So we live with our communities. So, and there's a lot of factors we have gone through that list, which will shape up our behaviors and how we respond to those challenges, And I remember when I was a young trainee in West Midlands in the UK a long time ago. So we had a department of public health in Birmingham University, and it used to be called social medicine department. So, and it's a term which we don't use it anymore, social medicine.
Yes.
Yeah. And there were pretty academic units that did all the research in the social behaviors. And I remember many social epidemiologists, but they used to go to the communities. For example, we have many studies done in prisons, in the mental health hospitals, where you spend time with that community and learn how they behave and try to understand why they're behaving in that way, for example. So we have lost a bit of that bit over the last few years, because we are going in a direction. But certainly that laid the foundation, and especially the way our social factors, which are multiple, so it's a countless list, So, and the challenge is how we address them, especially in the modern world. So thank you very much. So I think I will open the floor for the questions, see how many questions we have for you, Dr. Dean. So I'm sure we'll be able to take those questions. Okay, so let me open my box whether I can see any questions.
So I see some in the question and answer, and I see some in the chat.
Yeah, there is a questions about COVID-19 pandemic death, how social determinants of health perspective could be prevented. And this question is from Prof. Muhammad Sheikh Hassan.
Okay. So I think this question might be asking is how could we have used social epi to think about preventing more COVID-19 deaths? I think that's what maybe the point of this question. And so one of my colleagues and I have actually written about this. Julia Raithman and I have written about this, that part of what I think that there wasn't enough of a focus on occupational health and occupational exposures when it came to COVID-19. When COVID-19, right, people that were the frontline workers, people that were people that were essential workers and that had to be at work. I said, this is a US-based example. People that had to be at work were not allowed to be quarantined or things like that, right? Had higher risk. But when we thought about who was getting prioritized for vaccines, we didn't always prioritize people based on their occupational risk. And what that actually led to was seeing disparities, because in the US, a lot of people who were in certain careers, for example, the minoritized populations tended to be in those careers that couldn't quarantine. So it led to disparities in the COVID-19 rates and deaths, but the disparities were really caused by the fact that we somewhat did not fully account for the types of jobs that people had. And we probably could have better prevented cases had we focused our vaccine efforts more on jobs than on some of the other factors that we did. I would say that was our example. I also think that we could have, again, we could have thought differently potentially about the risk of COVID-19 and even the policies that we have around how to get people vaccinated. If we would have had a bit of a more social epi approach, we might have used more social networks to get people vaccinated rather than public campaigns. Because most of the time when people decided to make a decision for the vaccine, it was through a family member or through someone who they trusted saying that you should get this. Again, these are based on our examples. So we could have even thought about it in terms of interventions and really leveraging existing social networks. They did that later on. For example, they started issuing vaccines through people's religious organizations or other groups, those, but that was definitely not the first line. So I would say eventually we got there into terms of thinking about how to incorporate a social determinants perspective. But it took a while. We did not do that at the first pass. And I think we could have prevented more deaths had we done that.
Okay, thank you very much. So I think there's one other question, which is about that you described the multi-level modeling, especially in the ecological study design. So I think the question is how we can standardize those variables. So when we, especially in the comparative, the studies, which I did. Thank you.
Oh boy, that is such a tough question. And it brings up a really important point, which because social epi is so new, that many times we are reliant on data that are from other sources that we did not collect. So a lot of what social epi has to do, for example, is rely on data from the US Census or rely on aggregating data from other studies that have collected those data. And you're right, they are often not standardized. I have tried to work with some people who do data harmonization work to try to think about how we do that, but I don't have a great answer for your question because I just don't think that we've done very well as a field in doing that. So that's a really good point. The standardization is really a problem.
Thank you very much. Thank you. Any further question? I'm just trying to look at the, okay.
Someone said, is there an overlap between the upstream and downstream factors, and how do we translate these theories into practice? So I would say upstream and downstream factors is kind of a narrative term that we use, and I would say not even everyone would agree on where upstream starts and where downstream starts. So one, I wouldn't say that we are held rigidly to saying where one starts and where one ends, but I would say in generally we don't talk about them being overlapping. We would usually in a paper or something like that, we would say we consider this as an upstream factor and versus a downstream factor. I would say when we say downstream factors, again, I think we're often more thinking about those things that are kind of more proximal than distal. Things that directly relate to someone's ability to get the disease, as opposed to those societal factors that might be leading someone to disease. And the question of how we translate those theories into practice. So I used to work in a school of medicine, and I got this question a lot. People would say, how do we, why are you talking about this? Is not something that we can intervene on. I think one, it's important to recognize that not all solutions to health problems are health solutions. So there are some things that we're just going to have to do outside of medicine that are medical practice that are going to influence people's health outcomes. I was looking at an example of this the other day when we were talking about challenges with housing, and how resolving challenges with housing actually ends up resolving many of people's health issues if they have unstable housing. That's not something that, for example, a clinician can provide, right? You can't necessarily write a prescription for someone to get a home. But if we really are thinking about comprehensively taking care of people's care, we might need to embrace the fact that we've got to go outside of, writing prescriptions over things that we think we can, or prescribing medicine to do that. I have seen some advancements in this. For example, more recently, I've seen people actually writing prescriptions for things like gym memberships so that people can exercise. But I think that I don't actually necessarily think that we have to think about these as influencing medical practice. It might not actually, but that doesn't mean that we can't think about using public health and medicine as tools to create the opportunities to intervene on them.
Thank you very much. I think that more recently, especially with the energy crisis in the West, and there are many elderly people who are suffering and they can't afford for energy bills, and then obviously we will see the more higher death rates among that population. So whether we can, do anything to prevent that, so obviously it's a big issue. But thank you very much for touching on to those points. I think we are coming to near the end of our talk. So I must thank you, Dr. Dean, for accepting, first of all, our invitation and being an excellent presenter for today's talk. So I think that's really been a privilege to listen to your talks, and I hope our participants have enjoyed that one as well. So I also need to thank all of you who participated in our webinar today. And you can get your certificate of attendance when you fill in the link on the survey in the chat. And I also want to thank those people who have made this webinar possible. It's the management team of our college and also the UAE University. And they've been supporting our organization of these seminars excellently. We have an organization and technical team in our department, Professor Michael Grimna, Mr. Al-Sajid, Mr. Ismail, Dr. Ifat, Mr. Banyan, and Mr. Amino, and our webinar coordinator, Dr. Azhar Kalal. They've been excellent. So lastly, our next webinar will be held on 30th of December, and we will announce the details of that webinar soon. And so if you want to follow us on social media, you can find more details on our website. And we look forward to see you again in 4 weeks' time, inshallah. So keep well, stay safe, and bye and wassalam. Thank you.